Zach, can you go to the next slide? So this seminar series is based on a project called MyCost, or Michigan Community Outreach to Address Financial Toxicity. This project is funded by a grant from the Michigan Health Endowment Fund, and the goal is to develop educational resources to help cancer patients and their loved ones navigate financial issues related to cancer and cancer treatment. Next slide. And as part of this, we've engaged a community advisory board of stakeholders, including cancer survivors, caregivers, and advocates. And I'd like to thank all of our advisory board members here for all the work that they've put into it. And I also want to thank Ali Faki, who's not here today, but he's been the project coordinator on this project. It's been absolutely wonderful to work with. Can you do the next slide? So today I am thrilled to welcome Drs. Lauren Hamill and David Doherty. Dr. Hamill is an associate professor in oncology at the Wayne State University School of Medicine. She's also the co-leader of the Population Studies and Disparities Research Program at the Karmanos Cancer Institute. David Doherty is the associate professor of clinical medicine at University of Pennsylvania and deputy director for clinical services at the Abramson Cancer Center there. And they both have, Lauren has academic expertise in cost communication, and Dave has both research expertise and also clinical expertise. He's a medical oncologist. We're really very lucky to have both of them here. They've been working together a long time. They've done a lot of really interesting work, and we're excited to have them both here to share it. But one more slide, Zach, before we get going. So if you have questions, please put them in the chat. We'll be monitoring the chat to ask questions throughout the talk, and then we're going to try to leave some time at the end for more discussion if we get through everything. And then we're also going to post a link to an evaluation in the chat. And to sweeten the pot and encourage people to fill out the evaluation, we are offering a $50 gift card. It's going to be a raffle based on people who submit their evaluation. So please get your evaluation in at the end of the session as well. And with that, I would like to turn it over to Dr. Hamill and Dr. Doherty.
Thanks, Teresa.
Thanks, Teresa. Am I able to pull my slides up? There we go. Thank you. So good evening, good afternoon, everybody. Thank you for joining us tonight. I was telling Teresa that in southeastern Michigan, I'm hearing some rumbles of thunder. So those of you that are around me might be hearing them as well. And I don't know about you all, but my neighborhood often loses power. So if I disappear, Dr. Doherty will take over.
And we're in trouble.
Yeah, no, Dave and I have been working on issues related to financial toxicity and discussing cost concerns with providers for a long time. I like to joke that he took the wrong seat at a conference once because I was just like, hey, what do you think about this idea? And that was, I don't know, like 6 years ago. So either was a good idea or he knew it was so bad that I needed guidance. So either way, we're here together today to talk about this. So part of what motivates my interest in this, and I think Dave's as well, is the kind of emerging and persisting problem of financial toxicity, which of course is why you all are a part of this group too. Data are showing that up to half of cancer patients in the US are experiencing something related to financial toxicity, and that experience can take the form of a number of different issues, right? I mean, you can talk about kind of clearly like direct out-of-pocket issues if you're talking about like insurance premiums or co-payments for appointments, but also more indirect things too, right? Like taking time away from work, which means you're not earning, needing resources for transportation, needing resources to kind of take care of the rest of your life that you can't take care of, whether that's looking after your children or looking after other relatives that might need your help. So all of these things are kind of adding up into a not so great experience for a lot of patients. And we see this, its effects take the form of a few different ways. Clearly there's financial consequences, but we also know that there are physical and psychological consequences. So, in addition to the stresses of a cancer diagnosis, you're also experiencing the stresses of either, actual or, experienced financial problems, or either anticipated ones that you think may come down, down the pike. And there's a growing body of research that is showing that, the issues related to finance and treatment are, it's resulting in patients not adhering the way that we would want them to. We're seeing that costs influence both what's recommended by providers and also the decisions that are made by patients. We know that an increase in material costs, but also the psychological consequences of feeling that financial toxicity can negatively influence treatment adherence. So that means patients aren't adhering to the treatment as prescribed. There's evidence showing that this could be a mortality risk factor. So like actually contributing, to mortality due to cancer. I just put a few bullet points up here, but really the literature has grown so much in the last 5, 6, 7 years. But as an example, a smaller pilot study, one of the first that kind of came out in this, found that 20% of patients are deviating from their treatment because of how much something costs. Another found that 45% of patients were not adherent to their treatment because of cost. And as oral, kind of therapies that you might not be taking in the clinic, as those kind of become more prevalent, there's a concern that adherence around cost will become even more problematic because people aren't in the clinic kind of receiving treatment, with the assistance and care of clinic staff. And I'm sure many of you in the room don't need this reminder, but regardless of insurance status, people are at risk for financial toxicity. So it doesn't matter if you have insurance through your employer or if you have Medicare or Medicaid, nothing is foolproof against protecting against this issue. And so, of course, our healthcare system in the United States is disjointed, isn't always well connected. And because of that, we need a lot of solutions to this. We kind of, there's no silver bullet. There's no, one size fits all solution to the problem. So rather we've agreed and we've argued that these solutions to this need to kind of take aim at every level of the healthcare system. And of course, there's things that can be done at the policy and insurance level. There's things that can be done at the pharmaceutical level. There's things that can be done at the organizational kind of hospital level. But of course, why we're here today is to talk about what can be done at that patient provider level. So when a patient is meeting with either their oncologist or nurse or a nurse practitioner or physician's assistant, what are some things that can be addressed or discussed about costs that can help either prevent financial toxicity from being experienced or at the very least mitigate it? So patients aren't experiencing this really, intense material and psychological consequences of paying for treatment or, the indirect payments of treatment, while also undergoing a very stressful point in their lives for treating a potentially life-limiting disease. So one thing that we've learned through research that we haven't done is that a major contributor to financial toxicity is a patient survivorship. Also know that patients aren't always aware of what resources are available or what kind of financial assistance is available or that they can ask for. For a lot of patients, if once you're diagnosed with cancer, this may be their first time kind of interfacing with the healthcare system. And so it's a brand new environment. They're seeking care for something, a really extreme diagnosis. And so they're kind of, out of their depths. They don't really know what to ask for or what's available. So often this lack of awareness means that patients are really unprepared. So in addition to having these things to deal with, they sometimes come up in a way that's a bit of a surprise. So a patient may start treatment and then, a few weeks or a few months into it, bills start arriving. Or they kind of, realize after a few rounds of treatment that they need to do more to kind of organize their lives to make sure that they're supported with things like transportation or even lodging if they have to travel far distances for treatment, how to take care of the rest of their lives, like their families and their jobs. So all of these things can kind of add up very quickly for patients and also kind of in a surprising way. Two of the major organizations that we kind of all operate under, and certainly Dave's in a better position to talk about these than I, as he's just been admitted as a fellow in one of these, which is kind of a big deal. The American Society of Clinical Oncology and also the National Comprehensive Cancer Network are these really like big organizing bodies. They kind of govern care and recommendations. And both of them have said, many years ago that patients and their oncologists should be discussing treatment costs. It's been important kind of at the organizational level for a number of years. The recommendations are, in print and people are aware of them. But of course, just because an organization says thou shall be done does not mean that it gets done. So we know from our own work that although the argument kind of behind these discussions is really strong, it provides patients an opportunity to talk about the things that they're worried about. It gives providers the chance to talk about costs and also effectively connect patients to resources. It can help inform treatment decisions and help identify patients who need help. But our research and others shows that these discussions don't happen. Even though patients and physicians self-report saying they want to talk about costs, they don't routinely occur. Our own work has shown that fewer than 45% of interactions with an oncologist include any cost discussion. Other researchers have identified this as an unmet patient need. And I think we can brainstorm among ourselves the reasons why these discussions don't happen, right? There's a million other things on the table. You want to talk about your treatment, you want to talk about your prognosis, you want to talk about other side effects. Also, talking about money is uncomfortable, regardless of the context. And, medical care certainly is one among them. Just from my kind of own anecdotal experience, when we've been working with patients on this, there's this kind of reaction where, I didn't even know I could ask this. And I think, certainly, in the last couple of years, we've seen kind of a change in this normalization, but patients still don't feel comfortable or like they know what to ask or how to ask it. And so this is what, the work that, Dave and our team have been working on for a while now. And one thing that we've done, and I'm going to talk about this a little bit more detail in a minute to look for your, kind of reactions and feedback, is developing an intervention for patients that they can use themselves to kind of provide them some support and some wording around concerns and really specific questions that they can ask either a physician or a nurse or another provider about the costs that are associated with their care or potential costs. And then also, if costs do arise, if there are resources available that can help support them one way or the other. And the intervention that we've adapted is something that's called a question prompt list, or QPL for short. And this type of intervention has been around for a long, long time. It's got a really nice history in academic medicine. It's a very simple tool for patients. It's just a list of questions. I mean, a lot goes into that list, but once it's kind of complete, it's a very efficient, very effective tool just for questions that patients may want to ask their provider. They've been shown to improve kind of how actively patients engage with their clinicians. They help improve the amount of information that clinicians provide. They help influence treatment recommendations, all the different things that are discussed within a given meeting. And importantly, it also influences positively the decisions that get made and then outcomes for patients. So in the moment, it's a tool to help encourage quality communication. But simply kind of intervening in this way can improve both physical and psychological outcomes for patients. So there's a lot of kind of bang for your intervention buck, so to speak, in these. And so we've spent a lot of time building and developing one specifically to the context of cancer treatment costs. And I could go into the details of the intervention, but I'm wondering, given kind of like our time constraints, if it might be wiser if I show you kind of what patients get out of it. And we've spent a lot of time distilling information from bodies like ASCO and from the NCCN, also other like hospital-specific resources that we have at Karmanos, talking with providers who provide care to cancer patients, and then probably most importantly, are patients who were either currently undergoing treatment or survivors of cancer who went over this with us, in a really collaborative, iterative way. Like, we spent several years working on this intervention before it even came close to being in the clinic. And so what Teresa suggested we kind of emphasize this evening is these are like the main questions that have, and we've distilled over several years worth of investigations. And so you'll see there's a list of 22. Typically, when we provide these kinds of tools, patients on average usually only ask about 4 or 5 because they pick out the ones that are most important for them. But you'll see they're kind of divided into different areas of focus, like the cost of an appointment or a treatment, understanding, what your insurance covers, things like transportation and parking. If you live far away from a cancer center, if you need to or want to continue working while you're undergoing treatment, if there are programs that offer assistance and support, what about the rest of your life, like your family and living responsibilities, and then, other general questions about cancer and treatment that patients can ask to kind of go along with these. So I know I've been kind of monologuing for the last 10 minutes or so. I want to pause for a second. Dave, if you want to weigh in on anything here too, I don't want to dominate the stage, so to speak.
No, I learned long ago that I learn more when you're speaking than when I'm speaking. So, no, I want to acknowledge, some of the comments in the chat from Anita a bit. I think, and we might get into this a little bit later with some of the work that we did on the physician side of this conversation, about these, historical concepts where people feel, even, I think it points out that physicians aren't always comfortable having these conversations, and we don't know the answers to a lot of these questions, but we can point people in the right direction, right? So cancer treatment has come a long way in my career. And, as an oncologist, I view this as a partnership. And, the advances in treatment don't do anybody any good if my patients can't afford them, or if they're interfering in their lives in other ways and so forth. So, I think what really intrigued me about the work way back when Lauren and I first met was I think that this is a really practical approach to be able to bring up some really important, but not often easy conversations, and, conversations that we all want to have, we know we should be having, but it doesn't always fit in really well. And so, I think the other things that have really sort of, how shall I say this, that I really think about when I'm talking about costs and treatments with patients is to Lauren's point earlier, there's the out-of-pocket costs and sort of the financial costs, but the economic costs. And many of the patients that I'm caring for, I treat patients with lung cancer. And the goal for many of our patients, unfortunately, is not necessarily curative, but helping folks live as well as possible and as long as possible. And that's where a lot of the costs of time and so forth come into play. And I think this also, helps spawn conversations around quality of life and people's values. And so I think that there's a lot of other benefits that we can have in the patient-physician relationship than just talking about costs and so forth.
And I think Anita made a good point there, where she mentioned that her radiation oncologist said he didn't want to talk about money because he was concerned that there was that he provides services based on ability to pay. And that's another identified, I've been talking about patient barriers to having these discussions, but as Dave kind of introduced, there are physician barriers too. I don't want to know about your finances because I don't want you to think that I'm prescribing something less effective or less good. Because it's, relatively cheaper or something like that. And I think that that's a logical kind of reaction to have. You don't want patients to think that they're getting something substandard. And also on the patient side too, mentioning cost can also bring up concerns about not appearing committed to your treatment. About this piece of it, you're going to be seen as a bad patient or something, which I research, not just anecdotally, but published work has identified that as well. So I think there's a lot of things coming from both sides of the conversation that prevent high quality discussions to happen, and especially early on, because I know I've obviously with Dave, but with our other clinician colleagues too, it's these issues will come up one way or the other, but what you'd want to is have them come up before it's an emergency. And before you're scrambling to kind of retrofit a solution. So rather than, it's going to come up one way or the other, let's make sure it happens early enough into treatment so we can make a plan and anticipate, and be proactive, rather than hustling to be reactive, once there's kind of, more issues to address.
I think the proactive component, I can't overstress it enough, because there's so many opportunities for us to intervene if we know about this. And as the care team or as the organization, if folks, pay for an expensive medication, and it's a high copay or something like that, there's usually very little we can do after the fact. Mm-hmm. And so, having that dialogue in a proactive fashion really avails us to more and more opportunities to intervene and to help. right? So I think that's, you know, the concept of what we're doing with this app, you know, really trying to prompt this kind of a discussion up front when we're making a treatment plan, when we can understand, okay, you have childcare responsibilities. Well, maybe we'll choose a different combination of treatments that only require you to come in one day out of every 3 weeks versus, you know, a couple of days in a row every couple of weeks or something like that, assuming they're the same, you know, the same in terms of how effective they are.
So one part that, you know, I should say too, Dave and I are in the middle, like we're like 2.5 years in a 5-year study testing the effectiveness of one of our interventions. And so we're collecting data on, once a conversation happens with a medical oncologist, you know, what type, if or how other providers might get referred to and patients connected. So Dave, I wonder if you might speak to some of this in your own practice, like who, if you encounter a question that you don't have all the detailed answers for, like, what do you do?
Yeah, you know, so, you know, cancer is the ultimate team sport, right, in medicine. And so, you know, I can't provide the care for my patients alone. So there's a whole team of patients, a whole team of providers caring for patients, nurses, social workers. You know, it depends on the organization. They might call, you know, people resource specialists who can identify resources available to patients and their families as they're going through this. So for instance, you know, some of this, you know, there's also this group of folks called financial counselors. And some of this information gets obtained, you know, at various places along the course. But, you know, for instance, if you were to say to me, look, you know, what's my copay going to be? I have no idea because of the way that our insurance system happens, right? Everybody's copay might be different. I've had patients who I've given, you know, very expensive medications to who I've been told, you know, got it for free because of their insurance and the coverage there, versus others who are going to have a $10,000 copay, right? And so, so it's hard for me as the treating physician to understand what your particular situation is. But that's where I have to leverage the experts around me to be able to connect you to the right people. I say, okay, I'll get you in touch with our social worker, or this is the number for our financial counselor. I'll make sure they give you a call after the, you know, after the visit, and we'll get this all, you know, sorted out in a way that you're comfortable with, right? And the way that we think is appropriate. So, you know, oftentimes I think folks feel like physicians might have all the answers, but in fact we don't. We have very few of them, but there are people around us who really help us tremendously. I'm just looking at the chat here also, and I see Gina's question about our hospital staffing issues being discussed as part of our research. As a nonprofit serving families who are facing financial toxicity, you find a lack of support on the hospital side. So I think that's been a really challenging problem that literally everyone has been facing. I think you know, during the pandemic, we had a lot of staffing issues. You know, post-pandemic, you know, life is very different. I don't know that we're specifically tackling this because a lot of this work that we've laid the groundwork for, you know, we did pre-pandemic in when the world was very different. But I don't know, Lauren, if you have any, you know, thoughts on that, or how that, you know, how that might surface in our work.
You know, I think it's funny because of all the issues that we've encountered while implementing this, you know, staffing issues really haven't you know, come up or been addressed. I think we've been able to, you know, we've situated ourselves in some ways to kind of, I mean, we certainly, you know, we sought out clinicians who were champions of this kind of work, who have a support staff who are willing and able to facilitate the discussion occurring, but of course, whatever results from that, you know. And we've had a lot of conversations with, you know, social workers, financial navigators, as Dave mentioned, also pharmacists. And so, you know, I think we're, you know, of course, everyone is struggling, but I think where we are, it's been pretty fortunate that even though people are, you know, doing more with less, we've still been able to avail of what's around us to help patients. So I mean, but this is just one cancer center. You know, we designed it with colleagues at Karmanos. We designed it to be implemented. I mean, not just in one clinic, we're in a variety of clinics, but it is, you know, kind of one central organization. So I think there's, you know, a lot of investigation to be done, you know, in different settings, especially smaller hospitals, I would imagine, because we are in a metro area. So I think we probably have a different, you know, environment than some. That was a good question, Teresa.
Yeah. Gina, are there particular types of staffing issues you're seeing that you wanted us to specifically comment on?
Well, I was just thinking about how the numbers of people who experience financial toxicity versus the number of people who are able to actually reach. And I know physicians see every patient, but social workers or other support staff don't often see the patients. And the people who typically ask these questions and have these conversations are in that support role as oncology social workers, et cetera, navigators and things like that. So in our experience, we really find that, we rely on the hospitals to make the patient referrals. And we feel as though a lot of patients are now trying to find us directly because there just aren't resources available to them. And unless they have a really great proactive physician, it's a big educational learning curve for the doctors, because their job, they feel, is exclusively to treat the patient medically speaking. But this is so important to that we feel the physicians should be more involved. But how do we educate them, and how do we get that conversation started? So what you're doing is great work. And I really support it and appreciate it. But we just have seen so many roadblocks in these past, especially few years.
Yeah, our system is incredibly complicated, Gina, and I don't need to tell you that. And I think, I alluded to this earlier, and Lauren will show a slide where we really tried to disarm the physicians a little bit around how to bring these topics up, because, like we mentioned earlier, there's a list of 1,000 things that we need to talk to with our patients about. And oftentimes, these important issues aren't near the top for us, and we have limited time. But we recognize that, perhaps it's an issue around resources, but perhaps it's an issue where it's not being brought up because the doctors aren't thinking about it, right? Or they're not comfortable, talking about it because they don't have the answers, right? And so, I think each organization is probably a little bit different. And I think, at least in the organizations that I've worked in, I've been at a couple of large, cancer centers. I've had many patients over the years who I thought were totally fine in this regard because they never brought it up to me, right? And so there was no way that I could make a referral because we just never brought it up. And we had the resources and we had the financial counselors, but there was just never an opportunity for us to bring it up until later on, actually, when things were already problematic. So I think for us at the University of Pennsylvania, one of the things that we probably could do better on is screening for this type of stuff and screening for social determinants of health up front. Now, there's always that, concern that if you ask these questions, then you're going to generate all this demand for the limited resources. But what I find in my own practice and in my role overseeing our cancer services here is that, really, oftentimes there's a very particular need that, our social workers or our financial counselors can help, folks deal with, in the moment. And then it's not like a continuous problem, that they're dealing with. So I think every organization might be a little bit different in this regard, but in my experience at the organizations I've worked at, I'd say the problems are multifactorial in terms of getting folks to the right resources.
And Gina and I have had conversations in the past too, so I know we've addressed this before. But as a part of this work, we're actually kind of building up a provider trainer. And again, this is for Karmanos, because that's where we are. But so we've been collecting kind of key informant interviews with different providers and looking to them or asking them, what is it that they want? How can we help them be better prepared for these discussions? And so we've collected a lot of qualitative data over the last couple of months, and we're working on building kind of an interactive training that providers can, kind of walk themselves through. So like making it something that's efficient, easily accessible, and something that they can return to. So ideas for like, kind of having responses ready to go, or, making them aware of what supports are available, because like Dave said, if it doesn't get brought up to him, he won't be able to make the referral. But I mean, I've talked with, I feel like I'm learning every day what else that we have to support patients, and I'll bring it up to physicians and they're like, I didn't even know that we had that. And so like having those connections and like no critique, because, our time is finite for a lot of things, but being able to plug our patients into people who are in positions to support them is just simply knowing that they're there. So we're definitely working on building this up to make it more kind of multi-level or comprehensive, and not exclusive to oncologists either, with the understanding, like as Dave noted, that maybe the initial discussion happens with someone like him, but the person who often facilitates, or navigates a patient through these issues is really the oncologist, him or herself. It's usually someone else. And so having kind of that initial conversation while treatments are getting, kind of decided upon and moving, knowing who patients can reach out to for that kind of additional support when they need it. And I think what I find particularly interesting is when I meet with like social workers, in particular, how they have their, they are, the experts in what's available for patients, and they're very good at kind of closing gaps in ways that may not be immediately obvious. So maybe a patient is having a hard time, paying for their co-payments. And, they'll say, well, maybe we can't do co-payments in particular, but here is, vouchers for like utilities or transportation or things like that. So like they're still able to kind of support patients, but maybe not in the most direct, obvious way. So I'm just, kind of putting that out there with people who know far more about this landscape than I do.
Yeah, I think that's a great point, Lauren. And I think at least in the interactions that I have with our social workers, our financial coordinators, is they're familiar with the resources not only within our own organization, but also within the community, which, I admit, like, there's no way that I could be aware of all of that stuff, let alone understanding what's happening in our own hospital. I think, Diane brings up a good point. And I think that, the point in the chat, just for those of you who may not be following the chat, is that there was a patient that Diane was aware of that couldn't receive surgery in a timely manner due to surgical nursing shortage at the hospital, and that is a very real problem. I think most healthcare systems are seeing a shortage of nurses, although it seems to be getting better, at least in some places across the country. But that has been a real challenge for a lot of systems and a lot of hospitals.
Can I ask a question of both of you? Maybe Dave in your clinical experience and Lauren in your research. So what are the kinds of things that an oncologist can be helpful on? And what are the kinds of things that an oncologist is going to say, that's important, and let me introduce you to this other person? So I know in some work that I've done with oncologists, like and Dave, you alluded to this earlier, being able to change treatment schedules and regimens in order to reduce the impact on work or caregiving or other responsibilities people have. But what are the things that oncologists can feasibly do? And what are things that would need to go to a different professional?
Yeah, that's a great question, Teresa. So just looking at the questions that are up on the screen, there's no way that I would know the answer to number one. How much will you have to pay for your treatment? But, a conversation around number two is like, okay, if there's another option that might be in general, less expensive, that's something that an oncologist, would be able to have a conversation about. Number of visits, things like, is there one of the questions I think is particularly relevant these days, does somebody need to drive me? Are services available closer to my home? As healthcare is changing and there's, larger systems and, sites within a larger system that are closer to home, maybe, away from the downtown site, there's more and more options for that. And so that's really something that I in particular talk a lot about with patients. Is it feasible for them to get their treatment at one of our sites closer to their home? Things like can scheduling treatment around, family scheduling. Can I work, which is, something else to think about. And my general approach with those types of questions is, yes, absolutely, we should work on that together. There's probably going to be some guardrails that we have, whether it be from a scheduling perspective or, this treatment has to be given in a certain way or what have you. Or, gosh, I think that based upon what we know about this, treatment and my experience in treating other folks with this same medication, I think you could probably get away with working, maybe with a little bit of flexibility or something like that. So anticipation of the treatment side effects and how that might impact the financial aspects of things, or more like the economic, impacts rather than financial, as well as, specific things about, the treatment choices, the network of where folks can get their care and so forth are really stuff that's in our wheelhouse. Most everything else we generally have to, leverage, our partners and team members. I don't know, Lauren, have you had,
I think our data are reflecting precisely what Dave said. And I think one thing I found a little bit interesting when we were doing our pilot work, and this was a much smaller scale study, it was only 3 medical oncologists and 32 patients, but the physicians that we recruited were really clear, like, I don't know if I'm going to be able to respond to this. And, it was kind of like, we're just trying to see if we can prompt these and sort of what kind of comes from there. But what we found really interesting was that in a given treatment discussion, patients who had the intervention, it was 50-50. The first kind of cost related discussion, it could have been initiated by the patient or it could have been initiated by the physician. But as the interaction went on, the physician started initiating more cost related topics. And so I think, I'm not sure if they maybe my definition of cost was too, or maybe their kind of assumption was that it was too narrow, but they were the ones who were initiating things like, and don't worry, you can drive, and don't worry, there's parking, and we have a financial navigator if you need it. So I think, once you start talking about like kind of like the broader definition of cost, which is what patients are experiencing, physicians will sometimes be like, oh, I talk about that all the time. It's like, yeah, I know, because I watch you. So it's certainly, I think, maybe kind of understanding what it is that patients need and how these are, kind of contributing to financial toxicity issues. I've seen their kind of, I want to say confidence. I'm not sure if it's confidence. But kind of knowing that they can address these issues with patients with with information that's helpful. They're not just simply saying, I don't know. And so, yeah, I agree with Dave on that, but certainly I do see a lot of discussions on, like, if you can hear the dog in the background, it's because the storm has started and now we're all upset. But the conversation around social workers and financial navigators in particular, I think is something that I've seen physicians get, really like effective with. Like, all of these questions are great. I don't have all of the precise answers for you, but when we're finished here today, I'm going to, bring in someone who can help you, or I'm going to give you the contact information of someone who can help you, or I will connect. There's kind of like a kind of closing the loop in terms of what to do next, even if that particular physician can't give the precise answers.
I'm looking at the comment about displaying flyers and posters and things, and yeah, that's a great question. I'll put my cancer administrator hat on, in that some of our organizations have strict policies around things that we can post and we can't post. But what I've seen done effectively at some of the places I've worked is QR codes. If there's a little, something on a QR code on a little handout or a flyer that can sit on a desk, patients can scan that. And then, to Teresa's point, getting to information digitally, I've seen that to be used as an effective strategy.
So I'd like to ask another question of both of you about, like, so what is it, like, Dave, what would prompt you to flag someone to refer them to social work or to navigation? And does navigation happen through, my impression is that social work typically happens because a clinician says, hey, I think this patient would benefit from social work, but please tell me if that's incorrect. And then is the process the same for navigation? Or what would make a patient get into that pipeline? And if a patient has concerns that aren't being addressed, what can they do to help get themselves into that pipeline?
So I would say, every organization is different, right? And navigation works differently from one organization to another. So I would say that the most reliable way for a patient to get themselves into that pipeline is to bring up these issues with your physician, right? There's nothing that would substitute for that. At our organization and at some others that I'm aware of, some of this gets surfaced as folks are.
I don't want to interrupt you. Sorry, I just want to ask you something. What happens if a physician dismisses it, like the example that we had earlier? Like, what would you suggest then? If one clinician is like, I'm not sure, I don't think we should be talking about that, or whatever. Sorry, I wanted to grab that thread.
Yeah, no, that's a great question, because sometimes you have to circumvent us. But that's where, you may have an opportunity as you're talking with other members of the team. So I think as a physician, I think the interactions between patients and their families and every member of our team is useful for me, right? So they may, a patient may not feel comfortable saying something to me, but they may say something to the scheduler, right? As they're getting things, scheduled for their upcoming appointment. Or they may make a comment to my nurse or the nurse practitioner that I work with or the physician assistant. So it's almost like, if you see something, say something, just like if you see someone, say something, right? Like if I've brushed it off or I haven't addressed it, you can either re-engage me as the physician and say, look, I appreciate that, that like in the instance that was raised earlier, I appreciate that, you have that concern and, but that's not a concern of mine. I know that you have my best interest at heart. Could we have this conversation because it's really important to me? That can feel daunting, right? But, it may feel different to have that kind of a conversation with the nurse and say, look, I raised this question, I asked the doctor this, wasn't quite sure, he wasn't comfortable or she wasn't comfortable, with this, could you help me? Or is there somebody else who you can direct me to? So I'd say that across any health system, any oncology clinic, any physician's office, the best thing that patients and their families can do is ask. With the advent of the, I don't know what you guys call it at McLaren, but the email, communication with physicians and care teams that can happen through the EMR, that's another great way to raise these, these questions. It's sort of a safe space. Hey, I didn't get a chance to ask this when we were in the room. These were some of the things that were on my mind. And you'll often actually get a different member of the team that's not the physician up front who can potentially direct you in the right, in the right way.
It looks like Karen has her hand up. Karen, do you want to ask your question?
I'm going to unmute. Yes, my question, and I think this is a very dynamic and needed conversation. However, with the physicians, the oncologists that treat our patients, and this piqued me when someone wrote in the chat that the education piece is needed for physicians and their team members. However, I know in certain cases, say, for example, in Dr. David's case, they may provide training on that specific topic in that particular environment. I think it's necessary that physicians obtain this training when they are in school. I think the educational process or requirements for physicians in oncology and other areas should include communicating with patients and the type of topics that they need to discuss and how to discuss it, especially with financial toxicity. Just a thought.
Yeah, no, I agree with you, Karen. I think it's now a lot longer ago than it seems that I went to medical school. And to be very candid, the concept of financial toxicity is pretty new, right? It's not something that, really we were thinking about or even using this language around even 10 years ago. So, when Laura and I met, this was sort of a bit of its infancy here. And I agree with you, like there's a lot that we need to do to adapt the medical education to the current, situation of healthcare in 2023 and beyond. Unfortunately, I think a lot of the training programs probably haven't caught up to it in financial toxicity conversation, but a lot of and Lauren and Teresa, who are communication experts, can correct me on this, but I think a lot of the underpinnings of high quality communication that we get training on to say, discuss difficult topics like end of life care or goals of care actually do translate to financial toxicity, whether we understand that and whether it's intuitive or not to us.
No, you're right. And I think I was going to respond the same way, Karen, in that, maybe the topic of finance isn't, maybe there's not like a class or a module on that, but there's certainly more focus on like patient-centered communication skills. And, we've talked about that, or that's been, an ongoing kind of push to have that more integrated into in graduate medical education. And that's become more standard. And I think Dave's right. Maybe we don't talk about, have specific lessons on talking about financial issues, but there's more instruction on kind of seeking out what patients are concerned about and what you can do to help support them, using that kind of focus on the patient and like, what are their values? What are their preferences? What are they concerned about? But I think, as this becomes more of a topic of conversation, I suspect that it'll become integrated in a more kind of standardized way for our younger physicians.
And Lauren is the one with real communication expertise. So I'm neither a communication expert nor a medical education expert, but this seems especially like something that would be good in a residency setting, like as opposed to main medical education, but really like once you're getting into actually treating patients and in your specialty and understanding the cost concerns within that specialty in particular. Because I think cancer, the issues around cancer are maybe different than managing heart disease or something else, some other chronic conditions.
And like what
Thank you.
noticed, and this is just, you know, me encountering physicians at different phases of their careers, but like, you know, I've used the word season to pull age out of it, but the more seasoned clinicians, you know, sometimes give me pushback. You know, the brand new ones are like, yeah, sure. What do you want me to do? What do you want to talk about? How do I say it? Tell me. And so it's like the kind of the attitude toward it is, you know, remarkably different.
Yeah. I guess I would also say that, you know, people like Lauren are few and far between, right? Who are, I think Carmanos is very fortunate to have Lauren there, who's able to, you know, provide this type of education, but not all organizations that run training programs are able to do that. There are national, you know, communication training programs that are more around, you know, difficult conversations, serious illness conversations and so forth that I think, you know, many programs can take advantage of, but clearly we can do better in this regard. And I think the point around, you know, training and making sure that we're preparing, you know, our physicians and our team members to be able to, you know, handle whatever is important to our patients is really useful. I'm just mindful of the time here, Lauren. There's great discussion and great questions. I don't know if there's anything that we wanted to show in terms of content, you know, later on in the presentation. But
Yeah, I mean, I didn't want to like I have a demo of our intervention, Dave, but I always have to preface it because we're in it. That we're not egomaniacs and in fact work for ourselves for free. So Teresa, do you think that's of any value at this point?
Sure, I think that would be great. And also preface it with like, is this something people could download and use right now, or is it only through the study, or is this sort of available for public use?
It's only available through the study right now because we're still testing kind of its effects. And what I don't want to do is release something that, I mean, because there's always a chance that it could be doing the opposite of what we want, right? And so we, you know, so far there's no indication that that's going on. But, you know, I would feel a little bit more comfortable to be risk averse in this way. And kind of hang on to it. But of course, the questions that we have listed up here, those are free. I mean, take them. I mean, we can send out copies because I think, you know, there's enough kind of evidence behind the questions themselves, but rather the kind of delivery of this is a little untested, I guess.
Yeah, if you want to, oh, go ahead.
Well, I was also wondering about the physician tip sheet, since that's come up and we've, you know, I think folks might find that interesting in terms of what we, you know, felt we needed to develop for.
All right, yeah, let's go over that first. In fact, I think I need to exit out of here because I'm pretty sure I blocked it out. So excuse me while I unhide it. Here we go. Yeah. So this, as I was mentioning before, we're building up the provider side of this to be way more robust than what we have here. But what we did was build a really simple tip sheet for physicians or really any clinician. And this is just one piece of it. I don't think I have a copy of the other side of it, but you know, we designed them to be, you know, you could trifold it, put it in your white coat pocket, you know, to give, you know, clinicians some reasons, like why is this important to discuss? And this isn't just us, like Dave and I are bright, but we don't, you know, we can't generalize across the entire cancer care system. So, you know, we looked to experts and organizations like ASCO and NCCN, you know, with like being very clear, like there's a purpose to this, right? And not just for your patient, but for you too. So, you know, emphasizing that doing this early on can help you both make a better decision, help identify patients. So Dave said, like being more deliberate with our screening, you know, this, I wouldn't call this a screening intervention, but it's certainly, if the conversation comes up, it can highlight to a clinician that this patient might need some additional support, or at least, you know, discuss to assuage any kind of like psychological concerns. You know, here we have data that most patients want to discuss cost with their physicians, but they're very happy to be referred to another provider too. And I think that's something we might not have said very explicitly yet, where patients want to have these discussions, but patients, patients are smart. They understand how our healthcare system works, and that even if the physician can't take you through every step of every piece of care, that they want to have that initial conversation with the person who's guiding their care, but then are very comfortable being referred to someone else who can support them kind of in a more detailed way. And then also just encouraging them, based on those kind of two big organizations like ASCO and NCCN, who have, stated, in writing that they're encouraging their oncologists to include costs in their discussions. And then as the other part of this too, we use the kind of barriers identified in research. And it's like, yep, you're not alone. A lot of oncologists are concerned that they don't know about cost concerns. They don't know how to respond. Emphasizing you don't have to have all of the answers. This can be a quick discussion in the moment, and then it can be referred to someone who can have a longer discussion. But it could really simply be a yes or no answer. Like, can I drive myself to treatment? Yes. That could be it. Of course, it could be something far more complicated than that. The concern that it takes too much time, which I also wanted to emphasize with this intervention. Of course, we're tracking kind of, in the moment while we're doing our big trial, but the littler pilot, patients were able to complete using the intervention in the time they were waiting for their oncologist, so that their time in the clinic was not longer. And importantly, while patients are meeting with their physicians and they have these tools, they don't extend time. So we're not asking physicians to spend an extra hour with each patient. Because I think sometimes when we talk about this with physicians, they'll see our list of questions that can sometimes get to like 45 or 50. And they look at me like, you are on something, lady, because there's no way that I am going to let that, into my clinic. But, the data are very consistent across, applications of this intervention in a number of settings. It doesn't extend the time. In fact, in some ways it makes it more efficient because you kind of have all of the questions sort of organized at the start of the interaction. So we're very clear that, talking about it in the moment can happen very quickly. And frankly, data will show that it'll save you time in the future because you have patients prepared, you're prepared. You don't have to have, the conversation again and again. And it also prevents kind of like that last minute set of questions, like sometimes they're referred to as like doorknob questions. So like as you're about to exit the exam room, the patient's like, oh, wait, I have one more thing. And it could be something like this. So it sort of prepares the patient and the physician to have a plan. I remember Dave saying to me once about patient-centered communication. He's like, the deal with it is like, if you do it well, no one's going to notice. But if you do it poorly, everyone's going to notice. So like, maybe you don't get a lot of accolades for being prepared this way, but it certainly saves you and your patients headaches down the road.
Yeah, Anita, we'll get one of these tip sheets to you to slide in your radiation oncologist pocket the next time you see them.
Yeah, you guys can just carry them around. We have a lot.
But what I think this is really helpful because, as we've said a couple of times here, as much as doctors want to have these conversations, they often feel ill-prepared. And I think sort of disarming them with this was really important, and providing them with, to Karen's point earlier, this is a bit of education that we can provide to them in real time that they could use. And they don't have to memorize it like we have to memorize a lot of other things. They can, refer to it as they need.
Are there any more questions from the audience, from the attendees? Anything else people want to bring up? Dave and Lauren, any more gems, tidbits, issues, thoughts?
I guess I hear people talk about normalizing, normalize this, normalize that, normalize talking about money. It'll save us all some grief.
One of the other things that both in work and personal experiences with cancer that I've come across is just like, understand too that like, even if you are able to manage your expenses in normal life, you're not meant to handle the out-of-pocket expenses of cancer necessarily. Like, those are a different kind of expense. That's not like the rent and the car payment and groceries. It's like, it can be very expensive very quickly. And so even if you don't see yourself as being someone who gets financial assistance in your regular life, this is different. And like, everyone should be getting some form of financial assistance in a cancer care setting, unless you have just spectacular insurance that covers everything, because this is really expensive. And so along with normalizing, it's also normalized just bringing it up early and often, and having that be the default of just discussing it and taking the temperature of how this is going to affect someone's finances before it gets to the point of getting bills that just literally can't be paid.
And I think a lot of the initial conversations I had with like nurses and social workers, they would say there's no average patient, but this could be a patient's first time encountering anything like this. And to that point, they've had insurance, they've, had their preventative care taken care of, like maybe they've had some like procedures, like a colonoscopy or, maybe like a small, surgical procedure, and it's always been covered. And so they kind of go into it expecting nothing to be different. And it is different, as Teresa points out. And she and I both are unfortunately in that position of knowing it personally and professionally, that when you encounter these and encounter this situation, this isn't like, I had to go to the hospital because I had a sore throat. This is something else. And that, I think that's part of the reason why patients get caught off guard is maybe there's concern about bringing it up. That's fine. But then also, why would they if they never had to?
Karen, did you have another question?
Teresa, I want to make a comment on something that you said that I felt is very important as far as conveying this information to the patient. There's always, in most cases, unforeseen financial costs for medicines, other complex health issues that may arise because of cancer. When should that conversation start? Because oftentimes when you start in that process, you're not aware of this may happen, or you may need this type of medicine, and you may have very good insurance and it's not covered. And then someone else mentioned there's like foundations and other areas that provide funding. And in most cases, patients are not aware of that. Say, for example, in my situation, I was not aware of all those resources that were available until the back end.
Yep.
Yeah.
That it is a very consistent thing that has been found in the research I think all three of us have done, and probably also in Dave's clinical experience, is that what 6 months after a diagnosis and well into treatment, you wish you had known at the outset, but you did not. You had to learn a lot of things the hard way. I actually recently, my mom has been dealing with cancer for the last several months, and even doing this professionally and having this experience here, I still did everything wrong. It was like I had never known any of these things differently. And so one of the goals of this grant that's funding these seminars is to help both develop educational resources around these issues and also get them to people. Mm-hmm. So one of the things we're doing is creating a website with some of the common information that people we hope could benefit from getting sooner rather than later. Sort of like a big sister sort of thing of like, well, this is something that commonly is experienced by cancer survivors, and here are resources that are available that you might not know about, might need. So if anyone has these, please send them to us. We'd love to share them with everyone. But what you're saying is very commonly reported of like, I wish I would have known then what I know now. It would have saved me a lot of headaches. And fortunately, most people don't deal with cancer over and over and over again. It's a one-time thing. I mean, it's sort of like, planning a wedding or something. Like you learn a lot as you're doing it, but you hope to only do it once. You hope to not do it over and over and over again. And the information is sort of hard fought. Anita, did you have a question? Oh, go ahead.
I was just going to mention, Karen, from my perspective, we put a lot of thought into this when we were designing the study. And so that app is actually administered at the second treatment visit, right, Lauren? Which is, the idea is that the first visit is often like you're just learning about things. There may be some information that you're still waiting on before you can develop a plan for treatment. So we figured the second visit was probably in most cases that treatment planning visit when you're having that conversation, say, this is the medication we're going to recommend, or this is the radiation that we're going to recommend. So I'd say that, before any treatment, is initiated is really a great rule of thumb. And then when there are changes in treatment being discussed, right? So that's when, there may be something different, either related to the copay or related to how the medication is administered, on what frequency. So how often are you going to have to be coming in for this medication versus the last one? So I would say before the initial treatment, and then at decisions where treatments are being changed along the way, are probably the two places where it's most useful.
Okay, thank you.
All right, I'm going to let, so Anita, it looks like you have your hand up. I think we're going to give you the last question or comment.
Well, I think it's important to understand and realize that that cancer patient on the first visit, the second visit, the third visit, or whatever, is still kind of functioning in a fog because they're just processing the information that they have cancer. They know that there's a cure but they have to contribute, but they're really not focused on the questions that are being asked now because they're really just trying to get through the thought that this is happening to me. And I think that that's something that we have to be sensitive to, that as a cancer patient or as a person who's accompanying a cancer patient, that there's a certain amount of fog that exists during the first month or so. And I think that has to be recognized.
Yeah, absolutely, Anita. I think there's just sort of that initial, the first things first, what's happening? What's the prognosis? What do I have? How do I treat it? Like that very initial, do I need to quit work? What's going on? Who's taking me to appointments? Like that things when you're like in the trenches and really dealing with it. And it's only after things sort of settle in, things feel, and you get to a sort of a new normal and you get used to what's going on, you can sort of start thinking about these other things like cost.
And money is not the
no
issue when you first go into treatment. That is not the issue when you first go into treatment. The first thought is, okay, make me well.
Yeah. Yep, absolutely. Lauren and Dave, any final thoughts or comments?
I just put our email addresses at the top in case anyone had any follow-up questions that wanted to go directly to the source.
Fantastic. Thank you so much, Dave. Any last ones?
Yeah, so many good points were raised tonight. And I guess what I want you to hear from me is this is important. As a cancer doctor, this is important to me. As I said earlier, the advances that we've made, they don't help anybody if patients can't afford it or they can't get their treatment. So I want you to, hopefully have the agency to bring these, topics up that are important to your doctors and your care teams. And if your doctor doesn't listen, go to the nurse. And if the nurse doesn't listen, go to the nurse practitioner or the scheduler. Just talk about it with anybody because, that's how we can be the most helpful. So thank you all so much. Really appreciate it.
Absolutely. I want to thank